Welcome everybody to the latest anesthesia video podcast. My name is Michael Irwin. I'm a professor of anesthesia at the University of Hong Kong and also one of the editors of the journal Anesthesia. And today we're going to be talking about an interesting manuscript which we've just put up on early view, so you can go to the anesthesia website and download that, have a look at that. The paper is entitled Postoperative Pulmonary Complications in Older Patients Undergoing Elective Surgery with the Supraglottic Airway Device or Tracheal Intubation. So I think this is a topic which is important for most of us because of the extensive use of these devices. And we have three of the authors of this paper, actually, including myself, but we have two of the more important authors with us today. We have Professor Li-Kun Yang, who is a professor of anesthesia and chief of anesthesiology at the Renji Hospital in Shanghai, Jiaotong University School of Medicine. And along with him, we have Dr. Ling Tu, who's a second-year resident at the Renji Hospital. She's in her anesthesia training. She also has some experience in basic science with a PhD as well as her MD. So the paper, just to maybe remind you, if I can read through, is looking at these two devices in older patients who were undergoing elective non-cardiothoracic surgery with positive pressure ventilation. And the objective was to determine whether there was any difference in postoperative pulmonary complications compared to the use of maybe perhaps more standard use of tracheal tube, which we see in many parts of the world. Now, my experience in Asia has been that the supraglottic airway devices are not used quite as frequently as I've seen in Europe, and there's a tendency to prepare the use of tracheal tube. So I think this paper is actually quite important because the demonstration that there were actually less postoperative pulmonary complications with the use of the supraglottic airway is something which I think a lot of my colleagues here would not have expected. There's a kind of a little bit of a prejudice and perspective that perhaps there would be a higher incidence of complications with the supraglottic airway device, particularly with positive pressure ventilation. So the fact that you found the opposite is I think particularly interesting. So perhaps the first question I should ask then, and to Professor Yang, is why did the study in the first place?
Actually, in many years of anesthetic clinical practice, we get to use another choice of airway control rather than intubations. Nowadays we get the supraglottic airways, especially the laryngeal mask. So someone said the laryngeal mask is very easy to placement and less sore throat, and also have many advantages, but still have some problem like higher aspiration risk or unsuitable for high airway pressure, like that. So some studies previously compared these two different airway stages. Then most of them are not so robust. Some said that LMA can decrease the in-hospital duration and mortality, and others in Lancet said associated with fatal complications in infants, in small children. And even recently in JAMA, Journal of JAMA in 2018, they found a higher 3 days survival with LMAs after the out of hospital cardiac arrest. So we got the hypothesis that maybe they feel compensating in hospital postoperative pulmonary complications with LMAs than the tracheal intubation, especially in elder patients having elective surgery with general anesthesia. This is why we try to compare. We try to find the advantages of incidence of PPCS when we apply in the supraglottic airways. Thanks.
Okay. So would you say that there, within your clinical practice in Shanghai, that there is a perception that there would be a higher rate of postoperative pulmonary complications with the use of supraglottic airway devices? Is that what you're saying? And that you wanted to demonstrate that this isn't necessarily the case? Okay. Yeah. So what, maybe can I ask Dr. Zhu, what sort of challenges did you face when you were performing this study?
Well, this is the first multi-center study that our team has ever conducted. So we encountered many challenges throughout the process. From study planning, design, ethical approval, study contact to data collection and documentation, statistic, manuscript writing, we encountered challenges every step of the way. And I think one big particular challenge was the sample size problem. Briefly, we wrongly took the total sample size for one arm and ended up recruiting more patients than calculated. But luckily, we gained guidance from experienced researchers, and we were able to address this mistake. So we learned a lot from this mistake. It taught us the importance of meticulous planning and double-checking calculations to avoid such errors in the future. It also taught us to always seek guidance from experienced researchers. A lot of people helped providing valuable insights and navigated this specific challenge for the study to complete. So we were really grateful for them. Okay.
So also, Dr. Zhu, do you feel that the use of supraglottic airway devices in China is increasing now? That it's becoming generally more popular compared to tracheal intubation? Yes, Dr. Zhu,
yeah, it has gained great popularity in China because probably because they are very easy to insert and they have many potential benefits in certain clinical scenarios. So they're really popular now. Personally, I'm conducting anesthesia this morning. I've used SAD for a knee replacement.
Okay, yeah. Would you say that for sort of routine elective surgeries, they're used in more than 50% of cases?
For elective surgeries, I think depending on surgical positions, if the patient can remain supine, then yes.
Lateral position?
Lateral position, probably not for lateral position, because anesthesiologists are concerned for leaking.
Okay, yeah, and not prone.
Prone, we never try. Maybe next time we can try. I have looked some report about the patients using LMA and the prone position. Prone position is actually hard to insert.
Well, it's not so much the insertion, it's keeping it there is the problem. I'm not sure it's really worth the risk.
Not prone position, no.
Yeah. Okay. So go back to Professor Yang, maybe you could tell us a little bit about how your study was actually performed, how it was done.
Actually, it's a very long time to.
Yeah. Maybe let's say maybe break it down a little bit. You used muscle relaxants in both groups of patients. I mean, obviously, I assume you're using muscle relaxants to intubate. Did you also use muscle relaxants in the supraglottic airway group?
Yes. they actually have two choice. One is to actually using muscle relaxant. Another is just use propofol, then insert the LMA. But in order to make these two groups compatible, then we use the muscle relaxation when we perform induction of anesthesia, and also write into the protocols. They try to get every center to understand and follow this protocol.
Okay,
thanks.
Good. Yeah. So what about the respiratory parameters, like tidal volume and use of PEEP and so on? Were these the same in both groups? Because you imagine they might have an impact on postoperative pulmonary complications. There have been a number of studies, for example, looking at the use of PEEP during surgery with ET tube.
Yeah. Dr. Chu,
Dr.
can
you answer that one.
They were not the same. As per our study protocol, the use of PEEP during anesthesia was left to the discretion of the attending anesthesiologist. So in our data, LMA group used less PEEP than ETI. This is because our study protocol did not restrict the use of PEEP and left that to the decision by the anesthesiologist.
Okay.
We designed the study this way because the potential benefits of intraoperative PEEP is still a matter of debate. And the appropriate level of PEEP is also uncertain.
In addition, actually, I think many anesthetists will decrease the level of PEEP when they apply the supraglottic devices, because when we try to compare the intubation and the LMA, in LMA groups, usually we don't use the PEEP level higher than 5 centimeter macro. Like that.
Yeah.
Yeah. So statistically, we found that they have different in the people difference in the people PEEP's level among these two groups.
Dr. Su, is there any different? Oh, sorry, do you want to add something? Yeah.
This is also the case for tidal volume, because we not yet know whether low tidal volume is protective.
Yeah.
So we don't restrict that in the protocol.
So a pragmatic approach, we would say. Good. Dr. Would you say there was a difference in the proportion of patients and the incidence of postoperative pulmonary complications between the patients having laparoscopic surgery versus open surgery? Did you break that down at all?
Based on our results, we observed 39% of patients who underwent abdominal surgery developed PPC. And the number was about 27% among patients who underwent laparoscopic procedures. But our study is not designed to answer that question. There is one study, though, concluded that open abdominal surgery is a known risk factor for developing PPCs. But our studies.
Yeah, I mean, it's interesting that these instances are actually quite high, 39% and 27%. But obviously, you were looking at fairly minor and transient postoperative pulmonary complications. What about the incidence of, say, pneumonia compared to your primary outcome? Since we're on that topic.
Sorry.
Yeah. So basically, I was saying that the incidence of postoperative pulmonary complications is actually quite high. I mean, maybe surprisingly so, in some ways. But you were looking at fairly minor and transient complications, obviously. And I think the audience might be interested in the incidence of like serious complications like pneumonia, and how that compares with your primary outcome?
We acknowledge that the primary outcome of our study mainly consisted of minor and transient PPCs. This is due to our study design. Most PPCs developed were classified as grade 1 to 2, and I think it's primarily due to the low-risk nature of the study population. In our results, the higher incidence of pneumonia was observed in the SAD group. It can be happened by chance because statistically, the difference was not significant. Also, our study was not specifically powered to detect differences in pneumonia rates.
Yeah.
I have to address that the statistical result was consistent in all of our dataset analysis, including ITT, including PP. So we cannot conclude that SAD is associated with more pneumonia.
Okay, good. Thank you very much. So maybe we move on to the implications of the trial, what we can sort of learn from this. Professor Yang, what would you say is the most important message that you would like to put out from your study?
Yeah, actually, in all studies, we got a primary conclusion is just supraglottic airway may be preferable in healthy elder patients and granted no cardiac surgery. If you perform the elder patients, not emergency, if the patient have no contradiction of use supraglottic airways, then just do it.
Yes.
This is most important message from this stuff. Thanks.
Yes, and given the fact that we're dealing with older and older patients, and in fact, although we've got having an older population because of advances in healthcare, many of these patients are actually, reasonably healthy despite their age. So the supraglottic airway device appears to be preferable to endotracheal intubation in that important group of patients. So I think some, the take-home message is very clear. I think it's a very interesting and pragmatic trial with useful results and implications for patient care. Just while we've got a little bit of time, I think our audience might be interested in anesthesia in China as a concept or whatever. Could you tell us something about the current state of anesthesia research in China? Your experience, from a university hospital. I mean, your hospital was now, I think, nearly 200 years old, I think, isn't it? 170 or something. Seen a lot of changes over the years.
Well, from the personal opinion of mine, actually, I served the area of anesthesia and critical care nearly 30 years, and I found the great changes. Overall, China is becoming a prominent player in both clinic and laboratory-based research around the world. Consider China's first bigger surgical populations. Actually, in years of 2022, maybe we perform around China more than 70 million of surgical cases. This is a huge number, 70 million surgical cases. One can export a larger number of the high quality clinical research publications. As a researcher, we surely do feel the country is investing significant resources into both the clinical and also laboratory research in recent years with the development and deepening neuroscience, molecular biology, and artificial intelligence. I'm sure there will be many more good basic research. in the future. And around China, we also supported by the government of project of brain in China. It's a very, very big project. Also, a lot of anesthesiologists participate in this project. In a word, I believe the state of anesthesia research in China is on the rise.
Yeah,
It's getting better.
I mean, I think you know, given the very large surgical population and often you know, very big hospitals. I mean, I don't know how many operating theaters do you have in your hospital in Shanghai?
In my hospital?
Yeah.
Oh, in my operating rooms, last year we finished 60,000 cases.
Yeah.
Of surgical cases, 160,000.
Yeah. So there's a lot of potential for
around China.
A lot of potential for, I think, for good clinical pragmatic research, looking at, you know, perioperative outcomes and so on. You know, evidence-based medicine, perhaps organizing groups to do this in a sort of multi-center basis is a way forward, I think. Dr. Zhu, what do you feel now, having, you know, been involved in some research and done PhD and so on? Is there anything you think that the journals can do to help Chinese researchers?
I hope the journal can pay more attention to large RCTs involving Chinese participants. This field is experiencing rapid growth right now. Currently, number of high quality Chinese clinical research does not correspond proportionally to China's vast population. I'm sure there will be more in the future. And so I hope more attention can be paid to these studies. This attention will definitely help us enhance research quality and also maximize the utilization of these big patient resources.
Well, that's great. And thank you very much indeed. I think that we look forward to seeing more high quality research coming from China, and particularly from Shanghai, which is one of my favorite cities in China. Always love to visit Shanghai. And to say thank you very much again to Professor Yang and Dr. Zhu for taking part in the discussion today. Okay, thanks, guys. Bye-bye.
Thanks, Professor Irwin. Thanks. Bye. That's a great meeting. Thanks.